All right, welcome to tonight's lecture with our guest, Dr. Matthew Loftus, hosted by the Gady Institute at Westmont College and co-sponsored by the Sociology and Anthropology Department and the Pre-Health Club. My name is Blake Kent. I'm an assistant professor of sociology here at Westmont. And I have to admit, I've admired Dr. Loftus from a distance for a number of years now, ever since I first read his work when he was a columnist for Christianity Today magazine. I invited Dr. Loftus to join us because he's capable of coming alongside our college as we continue to change and to grow as a learning community. We've, of course, had pre-health students here for many, many years, but we've also begun to offer courses more recently in global public health, in the effects of climate change on health and well-being, and soon we'll be offering a course as well on the social determinants of health. As many of you know, we're also preparing to launch a post-baccalaureate nursing program in the spring of 2022, and understanding how social factors contribute to health and illness will be a foundational objective of that program. So I'm very grateful to have Dr. Loftus agree to speak with us tonight. I'm really eager to hear what he's prepared. As a heads up, the format for tonight will be the lecture followed by a Q&A for about 15 minutes. And we will endeavor to end promptly at 7:30, because I know many of you have commitments you need to be at. But now I'd like to invite Christian Kim, president of Westmont's Pre-Health Club, to introduce our speaker for us.
Hello, everyone. Thank you for coming. My name is Christian Kim. I am the president of the Pre-Health Club. And I am happy to introduce our speaker today, Dr. Matthew Loftus. Dr. Loftus is a family physician working in Latane, Kenya, at the Africa Inland Church Hospital with his wife, Maggie, who is a mother, baby nurse, and full-time mother of 3 children. Dr. Loftus attended school at University of Maryland, School of Medicine, and went on to complete his residency at MedStar Franklin Square Family Medicine Residency. Since then, he has worked in South Sudan, and now Kenya as a family physician and faculty member for the Kabarak University Family Medicine Residency in Nakuru, Kenya. When he is not seeing patients, training residents and interns, or running a mental health clinic, he spends time writing and making music. My personal favorite being Come Out Swinging. He has published on many platforms like Mere Orthodoxy and Christianity Today, writing on topics incredibly important for Christians to think about. To name a couple of his works, he has written about why Christians of all people should get their vaccines and the need for neighbors. If you'd like to read more of his works, you can visit his website, where you can also find his children's wonderful and incredibly exciting career aspirations. I'm also excited to hear what he has to say, so I'll turn it over to Dr. Loftus.
Well, thank you, Christian. That was a very deep dive into my background. And thank you all, and thanks Blake and the Institute for welcoming me today. I'm really excited to talk about social determinants of health, and also a little overwhelmed because no one can tell you everything that needs to be said, or even everything that's interesting about the social determinants of health in 40 minutes. For those who aren't familiar, the formal definition is that they are the conditions in the environment where people are born, live, learn, work, play, worship, and get older that direct a wide range of health, functioning, and quality of life outcomes and risks. That's from the health department website. So that is a lot of different things. You might say practically everything. We don't want to say health is everything. That's a different thing. So it's easy to go in a lot of different directions here. So I want to focus really on just 2 specific topics within that. And that's acknowledging that there's a lot of things I'm not going to talk about, or other things, but I just sort of breeze by. Like Christian said, I've written a lot about other topics in health and social determinants in other places, and you can look those up if you want to. And of course, we'll have time for questions. So what I'll do is I'll start off with a little bit of my story and the work I've done, move on to one big picture idea that I think is really important to understand about social determinants of health, and then a smaller, more granular thing, something a little bit more practical for everyone to go out and try. I know that there's a lot of different students here, and I thank you all for coming to listen in. And I know that you guys represent a lot of different disciplines. But because this is the pre-health students and the sociology anthropology club, I'm just gonna kind of refer back to two different classes of people. One is, I'm assuming that some of you will go out to work in the health professions and go out and be, you know, doctors, nurses, physiotherapists, counselors, individually seeing patients out in those kinds of contexts. And then I'm going to assume that there are some other people out there who might be doing big picture work, thinking about policy and advocacy and all that good stuff. That's how I keep it straight in my own head, because I like both of those realms as well. I love seeing individuals, taking care of them, and I love, you know, thinking about the big questions and trying to address the topics that affect lots of different people. But again, those are just kind of two poles on a spectrum. So my story is that I grew up in the suburbs outside of Baltimore, always wanted to do some kind of cross-cultural missions. If you ask my mom, it started when I was about 5. I really loved writing, became a chemistry major, realized I was not very good at research, decided that medicine was the best fusion of my passions, and through that did homeschool, community college, state university, state medical school. I lived in downtown Baltimore, in medical school, and then my 3rd year I got married, and my wife and I moved into a neighborhood called Sandtown in West Baltimore. So if you remember when the Black Lives Matter movement was starting, one of the big protests was around Freddie Gray and that incident. So at that point, there were pictures of Baltimore on CNN because there were parts that are on fire. That was kind of right next to where I lived. So that just kind of gives you a context for what the neighborhood was like. It was definitely a rough place, but also a place where we met a lot of really wonderful people who are still our friends and will be our friends for life. It was a neighborhood where the social determinants of health affected people a lot. Life expectancy in Sandtown is 65, 66 years compared to other wealthier neighborhoods a mile away, where the life expectancy is closer to 85. So 20-year difference in just 2 different neighborhoods. So we saw the social determinants of ill health all the time: open air drug selling, violence, poverty, lead poisoning, family breakdown. My wife and I became part of a church that was doing its best to serve people in the neighborhood, preaching the gospel in word and deed, and all the kinds of, you know, in many ways, it was an ideal sort of situation for us. If you've ever heard of the Christian Community Development Association, CCDA, and John M. Perkins' model for relocation, reconciliation, redistribution, and that's a whole nother multiple hour talk in and of itself. That's what we tried to live. Our first 2 children were born in that neighborhood. We became a part of that community as much as 2 white people from the suburbs can be a part of a community that's 99% African-American in a very different place from where we grew up. I did my family medicine residency at the hospital I was born at, Franklin Square. I learned a lot about mental health and primary care. At that point, my wife and I still felt called to overseas work, and we started preparing for that. I spent 1 year working at a clinic called Healthcare for the Homeless in Baltimore City, which was a really fantastic place to work. It was eye-opening for me working there because it was the first healthcare setting where I was surrounded by people who were constantly asking the question, what should we be doing to better serve our patients? That may seem like an obvious question that should be asked all the time, and yet I don't ever remember hearing it at the big city academic medical center or the community hospital where I trained before. Now they raise their butts off, raising money from every person in Baltimore with a dime to spare. That's a whole nother story, but it was really amazing to work there in a multidisciplinary team where I had social workers and addiction counselors, nurses and psychiatrists that I could collaborate with. And it really just shaped, even though I was only there for a year, it really shaped the way that I think and practice. I loved it, and I was sad to leave when it was time for us to move overseas. I spent a year in South Sudan doing mostly pediatrics and maternity care, delivering babies and training mid-level providers. Then the civil war in South Sudan came to our area. We had to evacuate, spent some time wandering around, and then wound up in Kenya at a hospital called AIC Latane Hospital. It's on the western side of the Great Rift Valley. I understand the climate is a bit like Southern California, always warm, sunny, never a bad day. And so now I do clinical and didactic teaching for all kinds of male professionals, and I help to run a family medicine residency, teaching family medicine residents and equipping them to go out and serve. So that's my background. I love clinical work. I love teaching. I love writing, thinking about the big questions of policy and theology. And so far from my adult life, I've tried to live with people I work with and serve. All right, so now on to the social determinants of health. So the first rule of the social determinants of health is that it's really, really difficult to do anything about the social determinants of health. I'm gonna pull up a slide here and let's see if I can you guys see that slide, or are you seeing yourselves? Where is that? Sorry. Yeah, so this is from health.gov, and this is the first, this is how they think about, they break down the social determinants of health into these 5 different categories: education, healthcare access, built environment, economic stability, social and community context. And so these are pretty important kinds of things, but they're also very big and nebulous sometimes. So here are some of the individual things that you break down. So reduce the proportion of children with a parent or guardian who have served time in jail. Very important thing. Increase the proportion of adolescents who have an adult they can talk to about serious problems. Increase the proportion of adults with broadband internet. Increase the proportion of people who have water systems for recommended amount of fluoride. All these, very different, very disparate, but big and complex things with different causes and effects. If you're an individual clinician, a doctor, a nurse, a physical therapist, or a counselor, you can obviously do very little in your individual encounters with patients to change these social determinants of health. If you're thinking about a bigger picture and wanting to set policy or pass legislation, then maybe you could change a few of these kinds of things. But even if you're an activist, a politician, a philanthropist, there's a few things that you could give away $10 million and that would fix the problem in a particular neighborhood, but not a lot, and certainly not all at one time. But think about, when I think about, when you listen to the rhetoric of health policy change, one of the holy grail in America is Medicare for all, right? That's the thing that a lot of people have been talking about for the last couple of years. That definitely increases access for people, and I think that would be a great thing. But a lot of people in America do already have subsidized healthcare through Medicaid. Obviously, that depends on the state that you're in, but where I learned and practiced in Maryland, especially after Obamacare, we had pretty good access to healthcare, and yet people still suffered a great deal from things related to the social determinants of health. So access isn't this magic wand that makes healthcare better for everyone. Just because you can get in to see a doctor or go to the hospital when you have a need doesn't mean that you're going to be healthy. So what law are you going to write that increases the proportion of children and adolescents who communicate positively with their parents? That's a really worthy goal, but you can't just give that to people. How are you going to decrease the proportion of patients who say that they have poor communication with their healthcare provider? That's another one of these health department goals. A lot of these things are outside the control of an individual clinician, and a lot of them are not easily changed by individual policies or law. So the next thing I want to show you is an illustration from a book called Health, Healing, and Shalom that looks at the social determinants of health, but looking at them from more of a theological perspective. So when you read Christian writing about holistic health and social determinants of health, oftentimes people are putting in, it's a similar kind of lens, but it adds the theological perspective and looks at, all of the other sorts of things, the political and economic systems that people live in, the community, the environment that they live in. But it also looks at, people's spiritual freedom and their spiritual, and especially emphasizes their relationships with others and their relationship with their community. And, I think that's a very important emphasis that's easy to forget. Excuse me. A lot of times we like to use the word shalom, the Hebrew word shalom. You may have heard that before. Literally translated, it means peace, but there's not really a good translation for that in English, because it's more than just sort of peace as the cessation of hostilities, but total peace in one's relation, harmonious relationships between a person and themselves, God, other people, their community, their environment, creation itself, other creatures around them. If you have a lot of relationships with, say, cockroaches in your house, as many of my patients have had over the years, then that's going to not be a very harmonious and shalom-filled life. Sometimes people like to say nothing missing, nothing broken as a way of summarizing shalom. Or shalom is like a tapestry where you have all these different threads that interweave all these different relationships that people have to think about their health. And so that's the vision of holistic health that we're often striving for and working for, trying to find a way to reconcile people and restore relationships so that everyone can be healthy. So now we've added more things to the social determinants of health and made them even more complicated. So if you look at, this is another illustration from a book called Health, Healing, and Shalom. And this is adding, now this is adding in other aspects, other things that can go wrong. So again, you have your systemic injustices, your broken relationships with community, your broken spiritual relationships, identity being affected. So, for example, fatalism and greed are things that very clearly influence people's health behavior. You only have to spend one day in a clinic somewhere, be like, oh yeah, wow. Can you ever pass a law that makes people less fatalistic or greedy? Not happening. So, oops, sorry, wrong mouse. So I want to sit here and feel that sense of powerlessness for just a moment, because again, there are a lot of these social determinants that influence health, and our control over these things is minimal at best. If you wanted to provide holistic healthcare for everyone, there's no mechanism for doing that, and you can't reimburse for it. There are very, very few clinics in the world, I would say, that seek to provide holistic health, that even have a strategy for doing that. And most of them are only available for very wealthy people. There's obviously a lot of things related to reducing poverty, which is important, although this is not a talk about how to reduce poverty. So we're not going to dwell too much on that. But I do want to think about bringing another theological concept, which is called the preferential option for the poor. And this comes out of liberation theology. What it says is that, if you look in the Bible, God looks out for the poor, the vulnerable, and the oppressed, especially when they have no one else to look out for them. God is on their side against injustice and exploitation. And so we should be too, because if God is on their side and we are not, then we are going against God. Paul Farmer likes to add, he's a physician, an advocate who's done a lot of great work on global health. He says that disease has a preferential option for the poor. Because of the social determinants of health, people who are poor suffer more from their disease and sometimes in unique ways. For example, if you can't always get bus fare to get to the clinic to get your medications, your HIV or your TB is at a higher risk of mutating into a drug-resistant strain. So one of the things that he had to do at his clinics in Haiti was to give people money for donkey rides, because they don't, in where he was working, people weren't using buses, they were using donkeys to get to the clinic. So it was a lot of academic papers out there now apparently about donkey fares. And that's kind of what you got to do, depending on your thing. So if disease has a preferential option for the poor, then medicine and public health should also have a preferential option for the poor. To be following, where's disease the worst? That's where we should be going. And if God has a preferential option for the poor, then Christians should also be following that route. But that's not always the way it worked out, unfortunately, because working with the poor is difficult. Reducing poverty is difficult. And even if you manage to reduce poverty, people who aren't poor still have issues related to the social determinants of health. Like we've talked about, like I've mentioned before, people who go to, clinics and hospitals that they can access with money, a lot of times they're still not getting taken care of. You think about people who, are wealthy and are still using drugs, getting very lonely, driving everywhere instead of walking, developing obesity-related diseases, maybe taking a bunch of horse deworming medication because it's something they read from their Aunt Gertrude on Facebook. There's an author that I really appreciate a lot named Bell Hooks. And she says, the well-off and the poor are often united in capitalist culture by their shared obsession with consumption. And this reckless culture of overconsumption is, I hope we can agree, destroying ourselves and destroying our planet. My wife was just telling me the other day, as I was workshopping all this with her, she was saying, well, think about how self-care has been twisted. Instead of doing things that are good for caring for ourselves, like turning off our phone, eating something healthy, and calling a friend and going for a walk with them, self-care becomes about buying something conspicuously and then binging on Netflix. That's not caring for yourself, that's self-medicating. And yet, caring for our bodies has become this meme that's all about consumption. So getting back to the social determinants of health, after a bit of a route trail into poverty, I want to emphasize that all of these social determinants of health can't always be changed through the levers of power that you guys are going to graduate into and take charge of one day. But that doesn't mean that they can't change. They can, but just not through the things that we tend to think about, because we tend to think about the things that we have some sort of control over. If you are a clinical provider, you are a doctor, nurse, physiotherapist, counselor, whatever, and you're seeing patients every day, things that might be better suited to some other realm of power dealing with things, get dropped in your lap because you're trying to care for someone's health, but there's no mechanism for helping someone have healthier relationships. And so, you feel powerless when you try to talk to people about having healthier relationships. Or again, on the other side, if you're activists, you think, well, there should be a law. And yes, there should be some very different laws about certain things. But there are a lot of things, again, that you can't fix with laws. It's the old adage, if all you have a hammer, everything looks like a nail. So when your hammer is the work that you have, the power that you have, then you're going to start using it in all sorts of ways that don't really matter. Another example of this that I hope is relevant to you guys is, the outrage of the day stuff that happens on social media. Have you noticed that a lot of it is about like symbols and speech? Like, even if it doesn't affect people one rip, whether or not someone said something or not something, or called it by a different name, if all you have is power over speech and naming, then all of a sudden, all of your interest and your energy and your power plays are going to revolve around symbolic gestures. So you could drag 5 blue checks on Twitter a day for being problematic, and it won't change a single social determinant of health, except for maybe your own. What does affect these social determinants of health, though, are families, communities, and small to medium-sized institutions. Looking at that slide from before, like a lot of this stuff is taking place in the context of these other institutions. So I like Alistair McIntyre a lot. And the way that he puts it is this: families at their best are forms of association in which children are first nurtured and then educated. It follows that the quality of life of a family is in key part a function of the quality of the relationships of the individual members of the family to and in a variety of other institutions and associations. And then he lists some: workplaces, schools, parishes, sports clubs, trade union branches, adult education classes, and the like. If you think about how you personally were formed into the person that you are today, there were obviously things where people with a great deal of power in an office somewhere else, individually or politically or whatnot, shaped your opportunities and what you were able to do. But most of the decisions that you make on a day-to-day basis that shape your holistic health, your mental, spiritual, emotional, and physical health, are the result of all the people who cared for you back from when you couldn't do anything for yourself but cry, to now, when you have teachers and mentors and friends who are helping you to set the patterns and habits that are going to be with you for the rest of your life. The virtues that you've learned through other people and the institutions that connected you, glued you to other people, are the strengths that make up your character and determine where, your direction, and in many ways, your health. So those were your social determinants of health. It's tough when other people don't have them. So again, from McIntyre, I promise this is his last quote for this lecture. If I am to flourish to the full extent that is possible for a human being, then my whole life has to be of a certain kind, one in which I not only engage and achieve some measure of success in the activities of an independent practical reasoner, but I also receive and have a reasonable expectation of receiving the attentive care needed when I am very young, old and ill, or injured. What McIntyre is saying here is that a community of acknowledged dependence is really key to becoming a flourishing person. Communities like this are places where everyone cares for those who are vulnerable, and those who are vulnerable know that they can receive care. And I trust that many of you grew up in communities like this. Maybe some of you didn't. There are unfortunately many communities across the world, like some of the ones I've lived in, where this was only partially the case. Again, going back to Bell Hooks, she talks about how the boundless desire to consume stuff turns into predatory behavior. And sadly, most of the time, when it comes to when you're living in, say, a poor community, a community affected by poverty, poor people steal from other poor people, and then the rich steal from poor people as well. So if you're poor, it really sucks because you're getting stolen from all the time because you're vulnerable. there are some ways in which poorer communities do foster a little bit more independence, interdependence, depending on other people. But unfortunately, a lot of that is offset by instability and violence. So the refuges for these communities, and I've seen this around the world, are churches, neighborhood groups, sports teams, after-school programs, local entertainment venues, community centers, places where people can gather and enjoy life together. None of these magically make any of the social determinants of health better in and of themselves, but they do provide the space and time for the relationships that foster better social determinants of health among people. So obviously, there's a lot of ways to support the relationships and institutions that foster good social determinants of health. But I also think that a lot of what we need to do to support these kinds of institutions has a lot more to do with a revolution in the way that we think about how we work, where we live, how we spend our time. So that's the first big point, is that social determinants of health are very important. They are not always easily subject to change. And the things that often change them are the things that are outside of the levers of power that we think about when we think about medical practice or advocacy or policy. But they happen in these other institutions and in families and communities. And this leads into my second big point, which is that if you want to be a part of these institutions and in building them up and supporting families and communities, you have to be a part of them yourself. And usually that means suffering with others. So this idea goes by a few different names that you'll encounter in the literature about it. Solidarity or accompaniment are two of the bigger ones that you'll see. And there's different nuances to each one. But the basic idea is that if you want to help people, you have to be with them. It's very difficult to love someone from a distance, which I think we've all been able to reflect on a little bit more in the past year and a half. And you want to be intimately connected to people in such a way that you share in their pain. Their pain is not an abstract thing to you that you feel exercised about, feel the need to post a bunch of hashtags and support, but it's a genuine sharing that comes through a relationship. So I'll give an example. If you heard that another student on campus, say, had been diagnosed with a particularly bad cancer, that would be terrible. You would feel bad if they, were keeping a blog. Never mind. Do people keep blogs these days? Or they were, posting about it regularly on their TikTok or Instagram or what have you. You would probably follow along and you'd empathize with them. But if it was your best friend, your roommate, someone you deeply cared about, someone that you already had a relationship with, that would be a totally different story, right? You'd feel their pain right alongside them every time their chemotherapy made them throw up. And that's the kind of difference I want to emphasize. When you have relationships with people who are suffering, then that changes your entire perspective on things and it changes how you help them. Paul Farmer, who I mentioned before, and wrote a book together with Gustavo Gutierrez, one of the most prominent liberation theologians. And they say, working for social justice means working with poor people as they struggle to change their situations. And I think this is really important, especially for those of you who are pre-health students, because when you enter the health system and you start working in it, you start taking care of people, the system itself will teach you to avoid suffering with people. And they will especially tell you, maybe not ever out loud, anyone will say this, but just the way that the whole system works is that you're supposed to really avoid suffering with somebody if the person who's suffering somehow deserved it or brought it on themselves. We call this the hidden curriculum. It's a whole way of thinking about and relating to patients that more or less teaches you to be really cynical, cold, and heartless as a means of self-protection against all of the terrible things that people experience and that you have to deal with. And I could talk for hours and hours about that. But I'm just kind of warning you that that's out there. You don't have to, go on a crusade the first time you notice it. Because figuring out how you deal with all that suffering that you deal with in the course of a clinical practice is, an individual journey everybody has to go on for themselves. But just letting you know it's there. And it's part of a wider backdrop in our culture of avoiding suffering, maximizing your privilege, and protecting yourself. And that's part of the world we live in. If you live in America today and you're successful, then a lot of the messaging you get from parents and peers and media is that you're supposed to live in the nicest house you can buy, the nicest school district you can find, or send your kids to a private school to keep them away from other kids who are negative social determinants of health as far as you're concerned, negative social determinants of educational success or whatever. We really tend to shrink back from suffering and death, especially if it feels pointless to us because we just can't deal with it. An example I'll give of this is thinking about how disability is visible in our culture, but only if someone who has a physical or a mental disability is overcoming and doing something incredible. If they're just feeling miserable or they're making someone else feel miserable because of their disability, that's not an inspirational post or a commercial, right? And yet that is the experience of so many people's lives. So to intentionally be with suffering people, whether it means like physically living in a bad neighborhood, like my family and I did, or spending your time with people who have dementia, or creating a church environment that is welcoming to people who are a little rough around the edges, that's crazy talk. But to our culture in Western society in 2021, but you will be transformed, and the way that you look at helping others will be transformed. So 3 reasons why this is important. Number 1, it's difficult to understand other people's pain if you're not with them. Number 2, people who are suffering often know the solution to their own problems. Number 3, Christian ethics doesn't really make sense if Christians don't suffer with those who are suffering. So number 1, it's very difficult to understand people's pain if you're not with them. So I'm going to show you a picture. And this is my hospital ward in Kenya. And so there's 2 different stories that I could tell you about this picture. I could say, man, look at this ward. It's so crowded. It's dilapidated. The people here are surviving on just a few dollars a day. We get these really sad cases where people have, full-blown AIDS. They come in right at death's door and we can't save them. The hospital needs me to see these patients. The nationals who work here are totally overwhelmed with patients and they're clueless about some of the diseases. Please, for just the cost of a cup of coffee a day, you can make a difference. Or I could say, look at this ward. The hospital just remodeled it. They actually replaced this floor with a tile one that's easier to clean. And they did it with fees that they collected because the hospital is financially solvent, which is a big deal when you are working with people that only survive on a few dollars a day. The hospital is trusted in the community, so people come here when they're sick, even when they're really sick, when they're desperate. This is a picture of me teaching African health professionals who are hungry to learn and they're eager to serve. You've probably heard both of these sorts of stories, and both of them are true in a way. I tend to stick with the latter because I think it's more reflective of the truth and more honoring to my colleagues. But you kind of have to be there to really understand which of them is more true. So I think this really applies to the social determinants of health, because a lot of times from a distance, you can only think about things from a 2-dimensional perspective: simple cause, simple solution. And then of course, social media makes it all worse. But when you're with people, you can really understand their problems. And then number 2, people who are suffering often know the solution to their own problems, spend time with people long enough and they'll tell you what they need. Sometimes this lines up with what the experts think, but often it doesn't. I think often of the story about this NGO that saw that women in this village were walking an hour a day to go get water from a well. So they said, all right, we're going to bring piped water into these families' houses. And so they built in all the water lines and all of that. And then the women kept going to the wells every day. And they were like, well, didn't we just bring you water in your house? And they're like, yeah, but this is an hour a day that we get to be together by ourselves, away from our kids, away from our husbands. And we have, we really cherish this time, walking down to the well to get water. And that's just something that you'd never appreciate unless you actually were with them. There's other stories. Some are more tragic, some are more funny. But outside experts try to do things and they don't often work. I'm not saying these solutions are always perfect or always the best thing to do, but you'll never get to hear those solutions if you're not like friends with the people that you're supposed to be helping. Because they'll point out flaws in your solutions that they will only tell to friends. And people will often nod along and go with whatever the outside experts say, because either they know that it's futile to resist, or they think, well, maybe something will work, or, maybe we'll get something else out of it. So, and then the last point, Christian ethics doesn't make sense if Christians don't suffer with those who are suffering. I am running out of time, so I can't talk a lot about this. But basically, we live in a time when we assume that suffering is inherently bad, especially suffering that we perceive to be pointless. Relieving suffering is good. And because science and technology help us to relieve suffering, science and technology are good. This is just, again, the water that we're all swimming in. But people 500 years ago that didn't have the same science and technology that we did had to deal with a lot more suffering. So they developed a lot more resources for dealing with suffering because a lot of it couldn't be relieved. And we still have a lot of suffering that we can't relieve: grief after a death, incurable cancer, mental disabilities, traumatic brain injuries, things like that. But when we hit those things, we really wish there was some kind of science or technological fix, right? And people are always trying to use the technology that we do have, even if it doesn't really fit. So now you have experts saying, well, if symptoms of grief persist for more than 2 weeks, consider using an antidepressant. I love antidepressants, don't get me wrong, prescribe them all the time, but pills for grieving? Are you kidding me? And it gets more insidious too. Stanley Hauerwas likes to point out that because medical science can't fix people who have mental disabilities, we get so ashamed of these deficits that we'd rather put those people out of sight in an institution or just eliminate the sufferer, kill them while they're still in the womb, and preferably. In 2019, 18 kids with Down syndrome were born in Denmark, for example, because if you can't fix the problem, if you can't eliminate the suffering, eliminate the sufferer. And so when science and technology allow you to make suffering optional, and the only thing holding you back is God's moral directives, then you have to, be willing to suffer with those who suffer in order for those moral directives to make any sense to people. We have to reject this incredibly common, incredibly pervasive view that because suffering is bad, you have to avoid it at all costs. We can't be Job's friends. The church has to be a safe place for people to suffer in. And Christians have to be known as people who are there for the suffering and with the suffering. So, and choosing to suffer with others changes others. Everything we know about the social determinants of health, because when you're with people, working alongside of them, not only are you learning from them, but you're also sharing your privilege with them in a way that a vote or a donation or a hashtag never could. It's more difficult, it's more uncomfortable, feels like you're accomplishing a lot less. So most people actively avoid it, but it's really rich and really meaningful. And I think that this is how Jesus came to us. He walked among us, moved into our neighborhood, suffered with us, and he equips us as that and gives us that model for how to love others, be with them, help them, love them where they are. And then you can be a part of the institutions that shape the social determinants of health for the better. So in conclusion, holistic health is not reimbursable. Health insurance isn't going to pay for it, but you can still be a part of building up holistic health, striving for shalom, building up the positive social determinants of health, and fighting back against the negative ones. You just have to recognize the limits of the power that we're used to thinking about and be willing to suffer alongside others like Jesus did. Thank you.
Well, thank you, Dr. Loftus. I didn't know what this was going to do or where it was going to go, but it was one of those moments where I really felt like you were saying just stuff that's just so true that I felt my I don't know, my heart and spirit agreeing with you and like really kind of going into reflective mode about my own way of approaching the world and people. So I really, really appreciate what you brought to us. We do have a little bit of time for a few questions. Students, if you have a question that you want to ask, why don't you just put a quick note in the chat, just says, I've got one. And as I see them come in, I'll call your name out. And I'll give a few seconds to see if anyone wants to jump in right away. And if not, I will ask a question to start, but I'll just give a quick second in case someone has something right now. Okay, so I'll start, and then as Dr. Loftus is responding, if you have the question, go ahead and jump in. I think so much of what you were saying and closing with was really meaningful and valuable to me. I think that as an undergraduate, I had this impression that the only way that I can really contribute to sort of the well-being of people in the world is by learning like this really direct application of a way to relieve pain or suffering. And so I think growing up in the evangelical world and kind of being exposed to ideas about international development or care and like medical missions and things like that, I think I had this idea that like becoming a doctor or a nurse or like a direct care provider was like the only way I could really do anything. And when it turns out that at the heart I was a sociologist and I wasn't going to go out and study physiology and all the things I needed, I kind of felt, honestly, I felt a little bit useless. I was like, well, I'm useless now. Like, what am I supposed to do? So I think you've started in touching on this, but I wonder if you can expand a little bit, because we have students that are going into the health profession. We have a lot of students here that are not as well. Are there like examples in your mind of colleagues you've worked with or people you've interacted with that don't have medical training, but have embodied some of the things that you've been talking about in a way that was meaningful and has contributed to the well-being of a particular community?
Yeah, no, that's a great question. Honestly, one of the people I think I've learned from the most in my experience in Sandtown, a guy named Elder Harris, who he was trained as an HVAC worker. So he spent, he had a career in HVAC, and then he and then he became kind of a pastor, community leader kind of guy. I think, there's a place for everyone. And, I think about, say, sociology. I think, I wish that more of my like medical colleagues just sort of thought about, okay, is the system that we're participating in, like, how is this affecting, how is this hidden curriculum affecting me? For example, like, how am I treating patients day to day? And so, I wish that there was some way that I could, magically beam some of some of that kind of reflection that you would get from a sociological perspective to them. But also, I think that, again, there's the direct work, but anyone in any kind of field can be a good neighbor, a good friend, someone who, there's obviously intentional, specific ways to do it, by, becoming a foster parent or something like that. But even just sort of being someone who is available as a friend and mentor and neighbor who listens to people when they're hurting and whatnot, like, I think anyone can do that kind of stuff. And I think that, that's really what's going to reshape the world. So much of clinical practice is, I get like 1 or 2 patients a day where I'm like, something I've done has definitely like made their life better. But all the rest, I'm just sort of screwing around, trying to figure, twisting the dials, trying to see if anything works. But who you are as a member of a community or family is I think far more important.
Thank you.
Mm-hmm.
We do have one question that's come in from Hans. So anyone else, please let me know in the chat. But Hans, go ahead and unmute and join us.
Hi, Dr. Loftus. Thanks so much for talking to us today. I'm actually one of your policy advocacy types of people, so hopefully I'll be able to work with physicians later on, but I really appreciate what you had to say. My question deals with your second point that you made about being intimately connected, because especially as we've gone through COVID, as you know, a lot more people have been resorting to telehealth actually. And I feel like we'll see a lot more of that later in the future, whether by necessity, comfort, or just accessibility. So I wonder what your thoughts are on how we would roll that out to be more intimately connected, and what you envision that would be like in the future.
That's a good question. I think that there's a lot of potential for telehealth to be helpful. One of the many things that I just didn't have time to include in my talk is just sort of this idea that if we really want good holistic health, we sort of have to put everything into the stratum or like the order of doing stuff that's useful. So for example, I think telehealth is a really powerful intervention for, say, specialty care. They're already rolling that out in Kenya, for example, where you have a cardiologist or a, kidney specialist, pediatric oncologist, who can see someone who's, everybody's got phones, and, if you can connect with someone in this rural clinic and say, okay, you should be giving this medication, this medication, then that's really super. And if that frees up healthcare resources for things like community health workers, who I think can and should be doing more stuff to, in terms of the relationships and, making those connections and helping people, to, to choose healthier lifestyles and things like that, then I think that's good. I think that it gets more complicated when it comes to replacing routine doctor visits with telehealth, because I can't tell you how many times that I have just, there's just something in the way that a patient is looking and speaking that just, you develop this sixth sense as a clinician where you're just like, something else is wrong here, and I need to ask some questions to try to uncover what that is. And sometimes I'm able to do that, and that's really great. And the patient ends up, pouring their heart out, and I'm able to really understand what's going on and help them to understand, I'm able to understand what's really on their heart, and am able then to shape my advice, and help them feel better about whatever is going on. And that's just, I don't think I could ever really do that on a video chat. So potential for good things, potential for eliminating some of those crucial interactions.
Great, thank you. We have time for one or maybe two more. I see that Sarah has a question.
Yeah, thanks so much, Dr. Loftus, for coming and speaking. My question was, you're talking about like Christians suffering with others. As pre-health students, what would you be like your recommendations for starting to do that so that later on we become more professional at that, I guess? Besides like the volunteering that we already have to do as pre-health students.
Yeah, I mean, I would say, just kind of find, I don't know what sort of volunteer opportunities you have. But and undergrad can be a really challenging time just because you're not always going to be in the same place after you graduate. But just, find ways to be a part of a community, whether that is, say, a nursing home nearby, or maybe there's a church in a rougher neighborhood where you can go and sit and learn. Homeless shelters, other places, other groups that you might have connections to, I think are good, or even within your friend circles too, I think is as an undergraduate are good places to not to spend time with people who are struggling and suffering, and help them to deal with things, and in that experience for you to grow. But yeah, it's a good question. And I think probably the most important thing that you can do now is to start practicing asking that question, and letting it shape the decisions that you make in the future. Because it is in some ways kind of like riding a bicycle, where, you just sort of start doing it, you fall off a bunch of times, it doesn't quite work out. And then once you do it, you can't stop. Like you just can't forget it. Yeah. So great question. Thank you.
Yeah, that makes me think of, I think in my college days and afterwards, I felt a lot more free in taking chances or risks, or being sort of in places of vulnerability with people. And I think in my own life, though, as I've gotten older and gotten, more education, and become more of an adult, and gotten married and had family, it's been harder for me to do these things. It's been harder because I'm not just putting myself in a position of solidarity with people that are suffering, but it's also, asking a spouse and children to come along with you. And so Dr. Loftus has talked about, doing that with his family. So I guess, Sarah, one thing that I would sort of just suggest, and maybe Dr. Loftus can respond to this as a closing comment, is that potentially just even now, when you're single, you have opportunities to develop habits and inclinations in this regard, so that you kind of can take that into future relationships and opportunities and responsibilities.
Yeah, I think that's a great way of summarizing it.
All right. Well, I'm so grateful to have Dr. Loftus with us, and all of you. I hope that this generates some thoughts and reflection and some conversation with friends and family as you continue to think through what it means to be people called by God, formed in his image, to love and serve all others who are also loved and made in his image. Thank you for everyone. Good night.
Good night. Thanks so much.
Thank you.
And just to add, if anyone needs, if anyone has questions about, global health and, serving overseas or stuff like that, My email address is just loftus.matthew@gmail.com. So I forgot to write that up there. And I'm more than happy to help answer questions that you guys have about that kind of career stuff.
Wonderful. Thank you so much, Dr. Loftus, and thank you to all you students. Good night.
Good night.